longer duration of unrecognized or untreated disease, the more likely patients are to develop stricturing as well as complications of disease such as food impaction.
Okay. Okay, so that's the correlation there. Okay, that's great. And so you mentioned that these patients showed sort of like, you know, the endoscopy is sort of like a common approach right now. A lot of physicians and especially physicians actually are doing endoscopy of the esophagus. It's a more common thing. Is there any challenge to that in some practices, you think, or is it something that it has evolved in a positive way and there are not really a lot of barriers to that anymore?
I don't think there's any barriers to at least a baseline endoscopy being performed. I mean, it's widely available, you know, at least in this country, in the U.S. and most, most countries, I would say, with the exception of, you know, maybe Africa or some countries like, but I'd say endoscopy is widespread. Everyone has access to it. And it's a standard of care to evaluate dysphagia. With an endoscopy. Some places may go to barium esophagram, but that's kind of slowly going away. I'd say the mainstay of diagnostic evaluation is endoscopy. So I think barriers to endoscopy could be insurance. If the patient's insurance has a high deductible, and endoscopy itself can cost, you know, thousands of dollars. So if a patient has a high deductible plan or does not have insurance, that could be an issue. But generally speaking, I'd say that almost in my experience, it's almost never the rate limiting step. When patients have a symptom, you know, they need to have evaluation and they get the endoscopy. I can't think of anyone who's not had it for the evaluation of dysphagia in my practice. Now, one thing that becomes a barrier is if they need a follow-up endoscopy.
I see. I was going to ask you about that.
We generally, you know, follow patients clinically. We follow their symptoms, and the standard of care right now is to follow their endoscopy with repeat endoscopy with biopsy to see what their disease activity is doing with therapy. And you know, although you know patients may be willing to shell out $500 for a baseline endoscopy, I think if you tell them they need another one, or you know, within a few months, or you know, even more than one within a year, I think then if they have a high deductible plan, that may be an issue where they really don't want to, you know, shell out of-pocket money to have repeat endoscopy. So I don't think there's so much a safety concern about the repeat. It's more the cost, and that becomes individualized based on patient's insurance status and their individual plan, whether it allows for repeat endoscopy to be performed.
Right. Makes sense. That's right. So in terms of this part of it, sort of the biopsy and, you know, the need for biopsy as a follow-up, to your knowledge, is there any advancement in terms of biomarkers that are less invasive? What is your take on that? I guess you know.
Yeah, there's a lot of interest, you know, on the research side to development of less invasive testing to assess disease activity. Some have gone to what's called transnasal endoscopy, but it's really an endoscopy, but it's done through the nose. It's an office-based technique that doesn't require as much anesthesia, so it might reduce the cost of the anesthesia, at least a portion of the scope, but it's still an endoscopy, still obtains biopsies. There's under development something called the cytosponge or sponge technique, which is a capsule-based Hello?
Yeah, I'm here.
Hello? Capsule-based technology, deploying a sponge about the size of a ping pong ball that deploys in the stomach and is dragged back through the esophagus, trying to detect disease activity. And there's another technology called the esophageal string test. It's being validated now. So all these are in development. I don't think any of them are really ready for prime time use. They have not been validated compared to the gold standard of a biopsy to an adequate degree. They're all showing a lot of promise, and you know, I would anticipate they would be very helpful for clinical practice within the next few years, but not in 2018.
Okay. That's good to know. So you mentioned briefly disease activity as, you know, you need to assess the disease activity in order to see what the condition is or how the patient is doing either before or after therapy. So is there an analogy between this condition and other conditions like you mentioned, IBD or other GI conditions where there is disease activity, but also disease severity.